What are the most heavily used modalities, right? CT, high-end interventional radiology, where if you're a level 1 trauma center and you've got stroke protocol and you've got to have a biplane IR suite up and running, those are crisis situations. You've got to be there, and the expectation is, at least in my experience, is the service engineer is packing up and you're unpacking and you're right there and you're getting it done. And that could be at 11 o'clock at night. That could be at 5 a.m. in the morning.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. All right, welcome back to Frame by Frame, Rethink Imaging. I'm your host, Chris St. John. Today, we are joined by Dr. William Breeden, a radiation physicist who has spent 23 years at St. Vincent's Hospital, over 27 years consulting. He has worked as a senior reviewer with the American College of Radiology for over a decade. He has been chair of the Nuclear Medicine Physics Committee for 15 years with OLA. I do have a bit of a connection with Will. We've spoken many times in the past. I believe one time I said when it comes to medical physics, he has more licenses than a DMV, and he is approved in more states than your favorite fast food chain. And I think that really still holds up. You know, on the show, we've been really looking at things from a higher level recently, lots of theory, lots of theoretical perspectives. And when talking to Will today, I really wanted to get our hands a little bit dirty, get into day-to-day talking about clinical practice. And I think Will really brings that rare combination of hands-on expertise with a critical theoretical eye. Will, thank you so much for joining us and welcome to the show.
You know, Chris, that was a hell of an intro. You know, when you say how long I've been in the business, it just makes me realize how old I am now. So it's been a long road, but thank you so much. I'm glad to be here.
Yeah, absolutely. Ignoring your age, but respecting the fact that you've been in this business for so long. How'd you end up here?
Yeah, great question. I was always in high school fascinated with chemistry and physics. I had a great high school chemistry and physics teacher. Just fell in love with it. Had a great math teacher as well. And I did a summer program between my junior and senior year of high school. And it was a health physics program at a local university in South Carolina, Florence, South Carolina, Francis Marion University. And I went to that summer program and came back and I said, I want to be in health physics. Most people think that's a PE teacher, but health physics is not. It's anything but that. It's more about radiation protection, radiation safety physics, and it combines all the aspects of chemistry and biology and physics and math together. So I went to Francis Marion and did my undergrad in health physics and did some summer internships at nuclear power plants. And as we know, at least up until this point, nuclear power has kind of been a dead, process in the U.S. They're not building any new nuclear reactors, at least up until, potentially they may start back, but not right now. And I was intrigued by the medical side. So, I went to my undergrad professor and said, I don't really want to work in nuclear power. He's like, well, why don't you go to grad school? And I'm like, Professor Hendrick, I don't know if I have enough money to go to grad school. And he's like, oh, Breeden, nobody pays for grad school. You just go and they'll give you some money. I'm like, so I started applying to grad schools and I ended up settling on University of Michigan and luckily got the Department of Energy Fellowship. So I focused on medical health physics in graduate school and worked with a physicist named Jim Carey, who is at the University of Michigan Hospital, also owns a big consulting firm in Michigan and Indiana now and Wisconsin and Utah. But at the time it was Michigan and Indiana. And I got a lot of practical experience with Jim and his consulting group while I was in grad school. And luckily, Jim offered me a job right out of grad school working in Indiana. And I was doing half of my time doing nuclear medicine physics, half of my time doing diagnostic physics. And that's kind of where it all started. That's the long, short story of it. Yeah.
I know I read some of the things that you've done, but just for folks, can you run through the list of your titles real quick?
So let's see. I'm board certified through the American Board of Radiology in nuclear medicine physics. I'm also board certified through the ABR in diagnostic medical physics. I have been actively involved in the American College of Radiology for quite a few years as a reviewer for accreditation for CT, MRI, mammography, nuclear medicine, and PET. And then I've served on the PET nuclear medicine physics subcommittee once, and I'm actually serving a second term. It's been a few years back on that committee for a 3-year term. I was on the CT accreditation physics subcommittee. I co-chaired that for about a month and realized I had not enough time and had to back out of chairing it. And then the American Board of Radiology, I have co-chaired the OLA program for nuclear medicine physics, which is basically the continuing education side of board certified medical physicists through the ABR. We basically write questions that physicists have to answer on a weekly basis, actually, in order to maintain their certification status. So I've done that since its inception, and I'm rotating off finally this year. I also serve on the American Board of Radiology oral exam committee for nuclear medicine physics. I just started that committee. The American Association of Physicists in Medicine, I served on the bone densitometry exam committee for the ARRT, which is the American Registry of Registered Technologists, and helped create that bone densitometry exam, help them with the physics questions on it. I'm probably leaving something out, but those are kind of the top highlights.
That's a good summation. And it kind of leads me to my first question, right? I really want to explore your day to day. You sit on all these committees, you're working at St. Vincent's, you've got your hands all over the place. Like, is there such thing as a typical day for you? Like, how would you describe your day-to-day work? Is every day completely different? Do you have a flow?
Right. So, yeah, that's a great question. So the thing about medical physics, the thing that I love the most and the thing that I hate the most are the same. It's that there's never any norm.
Right.
There's never a set schedule. You go into a day thinking, okay, I'm going to do A, B, C, and D. I'd like to come in first thing in the morning, check my emails, and then I get a phone call. We have equipment down. We may have a mammography unit that went down. And now I'm trying to look 2 days ahead to determine, okay, what do I have scheduled that I'm going to have to basically reschedule, because there's certain modalities that take more precedent over others just due to federal regulations, requirements like that. So, looking at those type of situations, juggling those, obviously normal routine scheduled equipment testing, that's a big part of what we do, going in and testing, CT, MRI, nuclear medicine gamma cameras, PET CT scanners, mammography units, ultrasound units. So all of those items have to be tested either through state regulatory requirements or Joint Commission accreditation requirements, or ACR, American College of Radiology requirements, or then there are other accrediting bodies now too, like RADSite, Intersocietal Commission on Accreditation, IAC. So there's a lot of moving parts, and you kind of always have something different being thrown at you on a day-to-day basis.
I'm really actually interested in is you're talking about testing all of this equipment. And sorry to the listeners if this is old hat to you, but I actually have no idea what that process looks like. And I would love to hear about that.
Yeah, so it all varies, right? So let's start with the basic, just a normal, regular radiographic room. You go in for that, you're going to get a chest x-ray. Maybe you hurt your hand, you're going in to get an x-ray. We have to do a battery of equipment performance test on that piece of, equipment. We want to check to make sure that, number one, is producing a good diagnostic quality image. And there's different ways that we go about testing those things, different metrics we look for in performance testing. We may look at the energy of the x-rays coming out. We want to make sure the energy of the x-rays are actually what we think they are when they're coming out. And we have ways to measure that. We want to measure the amount of radiation that's coming out per unit. We want to make sure it's reproducible. If I set the same exposure technique and I make 4 or 5 exposures in a row, do I get a reproducible, consistent result? Is the quality of the x-ray beam reasonable? And there's ways to do that. So if the x-ray tube's starting to get old or failed, the beam can actually become hard. And what I mean by the beam becoming hard is there's actually filtration that can occur and create some higher energy X-rays coming out than lower energy X-rays. And it can just kind of make the image quality an issue and radiation dose an issue.
Before you keep going, can you talk a little bit more about that, beam hardness? So is this like a byproduct of the machine itself? Is this what does that process look like, and how do you back it off when you find it?
There's usually some inherent filtration already between the X-ray tube and the patient. It's usually aluminum. Sometimes it can be copper, and it's a set amount usually. But then what can happen is as the X-ray tube gets, more and more exposures, it can actually build up a deposit from the anode being kind of like vaporized, and can put a deposit on the exit window of the X-ray tube, causing the half value layer to increase. That's what we use as a measure. It's called the half value layer. And, if we track that from year to year, and if we start seeing that creep up and creep up and creep up, we know that can be, a potential problem. On the flip side, if your half value layer is too low, you don't have enough filtration between the X-ray tube and the patient. And then you're getting a lot of low energy X-rays that are just contributing to radiation dose, but not to image quality.
Right.
So you always want your half value layer to be within a certain range, not too low, not too low, not too high. And again, that's one metric of many that we test. And it sounds like a lot, but normally you can test an X-ray unit short end 30 minutes, long end an hour, just depending about how many tests you want to perform and how much image quality testing you want to perform. There's also testing of the automatic exposure control. You want to make sure that that's functioning correctly. That determines how much, X-ray, how much radiation is actually going to get, pass through the patient, depending upon the patient's body size. And if that's not functioning correctly, you can have overexposure, you can have underexposure, you can have unreproducible exposures, you can have imbalance between the photocells. There's a lot of different performance tests just on X-ray.
Right.
And then we could talk about, CT, and we could talk about nuclear medicine, and those go on, and MRI, it goes on and on and on,
Right. And so you did say something, though, that piqued my interest. You said, depending on how many tests you want to run when talking about the X-ray, I'm curious, what is informing you as you are making that judgment call? Okay, yes, this machine is this has reached a sufficient amount of testing. Is it literally is it a predetermined list of checkboxes designed by organizational bodies? Is it what you're seeing and kind of that critical eye that comes with time and experience?
It's all of that, right? So at minimum, you're going to perform what the state requires, what the State Department of Health regulations require in your state, right? That's the minimum. You've got to do that. But you really need to do more. And most physicists do more performance testing. They'll follow American College of Radiology guidelines, which are going to be another step up. There's going to be more testing than just what the state regulations require. There could be Joint Commission required testing that's going to be a higher level, more tests than what the state requires. There's also American Association of Physicists in Medicine will put out task group reports, which are great. They're like the toolbox for medical physics of here's what you need, here's what we think you need to test, here's how you test it, and this is what the results should be. And so, between a combination of all those three, the accrediting bodies, the American Association of Physicists in Medicine, and then state regulations, it all comes into one package.
Right. And so, you did say earlier that there is a bit of an order of operations when different equipment is going down or what needs priority. But I'm curious, right? With all of these different modalities, PET, CT, mammo, nuclear medicine, with everything needing your attention at once, how are you allocating your time? How are you thinking about things? How are you trying to maximize efficiency, trying to keep everything up and running?
Right. I think, when it comes to equipment repair and post-testing, testing of equipment post-repair, those things you can't really plan on. So, whenever something breaks, it breaks. We don't have a predictor. Sometimes, on rare occasion, we can tell. Sometimes with mammography, the service engineer can check the life of the x-ray tube, and they have a kind of a general idea when it hits an exposure count, when there's been so many exposures, performed on that x-ray tube, they kind of have an idea that may fail. Or there could be some indications of some intermittent problems where they say, hey, this is getting ready to really go down. And then they'll preemptively determine we're going to repair this machine before it actually fails. And so when they do that, we can schedule that testing with them. So that's an easy thing. We can kind of plan on that.
Right.
The routine testing, the annual testing that we perform, those things can kind of get shuffled to the back if we have, for instance, a mammography unit goes down and the x-ray tube has to be replaced in the mammography unit. The technologist cannot use that. They cannot, expose a patient until we've tested it and cleared it. If they do use it, then they could get, basically a citation from the FDA during an inspection. So those things kind of take precedent. And the reality of it is that at some point, everyone has a crisis.
Right.
And so when it's your time to have a crisis, you expect us to be there on time. But when it's not a crisis and you have to get rescheduled, I think most local hospitals and departments realize at some point I'm going to need them and I'm going to have to bump somebody down the road to later testing. So it kind of comes back,
So, okay, we don't have to get too into things, but you said the word crisis, and I'm excited to talk about crises. I'm curious, can you just understanding privacy, understanding, be as vague or as detailed, as granular as you need to be. But I am curious, can you talk me through crisis, that maybe went totally off the rails and how you fixed it, or maybe something that you see regularly that is a recurring crisis? I'm just curious, what is this stuff that you are handling? What is the pile of stuff?
I think that if you look at what are the most heavily used modalities, right? CT, high-end interventional radiology, where if you're a level 1 trauma center and you've got stroke protocol and you've got to have a biplane IR suite up and running, those are crisis situations. That's when an x-ray machine, a biplane angio suite or an IR suite goes down. You've got to be there. And the expectation is, at least in my experience, is the service engineer is packing up and you're unpacking and you're right there and you're getting it done. And that could be at 11 o'clock at night. That could be at 5 a.m. in the morning. It's got to be because this is serious. The bottom line is, we're here for patient care. We're kind of in the background, but if things don't go well on the back end, it affects patient care. And, that's part of it. We want to keep equipment up and running so that when a patient's ill and they need to be treated, and they need to be seen, and they need to be diagnosed, that we can do that quickly. Obviously, I've spoken a lot about mammography. It's federally regulated. When that equipment's down, you have to they can't use it, right? And so they can be down. Sometimes it takes a while, for the service engineer to determine what is the problem. They may think it's one thing. They may think it's the x-ray tube, but then they realize after they've installed the x-ray tube, you know what? I've got to replace the generator too, because actually the problem's with the generator. Or there's another, situation where, you have crisis situations. You may have a department or a hospital getting inspected all of a sudden by let's say FDA or Joint Commission, and they want to see all of these things. And usually people panic, right? Because they're not used to going and finding all that documentation. So then a lot of times when that happens, we have to put our, Superman cape on and swoop in and provide all of the information that the inspectors or the surveyors are looking for from a physics and a radiation safety perspective. And, these things are usually happen on the fly a lot of times. So
yeah,
it's an interesting world, man. It really is. There's never a dull moment.
Yeah. It makes me kind of curious. What are some of the judgment calls that you have to make, right? In your day to day, I assume, you're going to be the guy calling some shots. Give me some examples of some maybe even more difficult decisions that you have to be making.
Right. I think a lot of times too, any patient safety related issues are precedent, right? they're number one. Someone got injured in an MRI suite. Someone got, God forbid, burned from an MRI exam, from RF heating. Those things, someone got an issue in the cath lab. These things are rare, but they do happen. Those things with patient safety always take precedent. So there's a patient safety concern. We take that very seriously. All medical physicists do. I mean, everyone that I know that's the number one issue. And, then the issue is obviously radiation protection. If we have staff concerns, if there's staff that are concerned about the amount of radiation exposure they're receiving, that happens sometimes. You have sometimes where you have issues between the technologist and the physician, and the technologists are saying, you know what, this physician's using way too much radiation. Now we got to go in and assess, like, okay, are they really? Do they need training? Do they need some reinforcement training? Are they new? Are they younger? Are they inexperienced? All of those things kind of go into play. So those things are definitely take precedent, always behind just routine performance testing of equipment. Obviously, during inspections by the State Department of Health or the Nuclear Regulatory Commission or Joint Commission, we are a liaison to help, provide the information that the surveyors are want to review and see. And then obviously we have to stay credentialed, right? Like, we have to find time to do continuing education, go to meetings. The plethora of amount of continuing education that we have to maintain is off the charts. I mean, it takes an army of people just to help keep me on track of what I got to be taking when and what's expiring when, and things like that. So it's challenging.
Yeah, I mean, it is a baffling number of moving pieces and parts that all need to be checked, like both personally for you as a physicist, but then also for the organizations in which you are working.
Right. Let me bring one other point up too, because I was speaking, in talking about crisis situations, it's one thing when you're an in-house medical physicist, but when you're a consulting medical physicist, you've got a whole nother level of issues because you're traveling, right? So you may be in one part of the state and 2 hours away or 3 hours away, or who knows how many hours away, depending upon how big your state is and what your coverage area is, you've got some other issue going on. So you always have to kind of like strategize geographically where you're going to be and make your time as efficient as you can, because you don't want to drive from, if your home base is in Dallas and you're driving to San Antonio, or some crazy place in Texas. I'm just using Texas as an example because it's a big state. You don't want to go and do one X-ray tube in San Antonio. If you've got equipment down, you're going to be like, okay, I got to go there anyway. Let's go see what else is due. What else could I maybe do a little early this year and make a solid day out of it, so I'm not going back making multiple trips. Just don't have time to do that.
Yeah. I've driven across Texas and I would not want to be going back and forth.
No, not at all. I don't want to do it across Indiana, and it's not half
yeah, right.
They're the size of Texas.
Do you do a decent amount of traveling or not too much?
Not as much as I used to. Yeah, back in my earlier days, I did a little more traveling. It just got to be too much.
Mm-hmm.
It's hard to do consulting across different state lines, things like that. You can do it, but at the end of the day, if you're not able to respond to a client's needs promptly,
right,
they're not going to be happy. A relationship's not going to last. So, it takes a strain on you. It takes a strain on the travel. The equipment's heavy. CT equipment is the 50 pounds minimum.
Yeah.
And you're having to try to ship that, or you're trying to take it on a flight. It's just really, it can get old.
Yeah, for sure. How long were you doing traveling?
Oh, a long time.
Yeah.
When I got out of, and I kind of talked, I started with medical physics consultants. I ultimately ended up leaving those guys in October of 2000. And I took a job in South Carolina with a great physics group out of Atlanta, Alliance Medical Physics. Love those guys. Love MPC too. They're all great companies. But with Alliance, the travel was all the Southeast. And that doesn't sound bad, but that's when you talk about going from South Carolina to Florida to North Carolina to Georgia to Alabama, it's just,
that's a lot.
Too much. Yeah. And so I kind of went, I left there in 2003 and started at St. Vincent Ascension in Indiana. And I've been there ever since. And I've been able to do some consulting when I have an opportunity through my advanced medical physics, which is now part of One Physics. But, there's a shelf life, I feel like, for extensive travel with this job.
Yeah, for sure. Is there anything that you kind of took from your time traveling that kind of like helped guide your on-site practice?
Time management.
Yeah.
100%. You have no room for error a lot of times with scheduling, and you have to be on top of things. You have to work later sometimes. You have to be willing to do things off hours. And sometimes consulting is like trying to take a sip of water out of a fire hydrant. It really is.
Yeah.
And it's funny, I've seen the progression of consulting medical physicists who have really been in the grind, right? Like, I know it, I've lived it. And they decide I've had enough, I'm going in-house. And they come in-house and there's this transition period because it's like everything's slowed down.
Mm-hmm.
There's still a lot of work to be done. There's still those crisis situations, but they're more manageable usually. And it's not as like chaotic. So it's funny to see the transition period because they're kind of like, I don't feel like I'm doing anything. I'm like, no, you are. You just you're doing it differently. And there's different things you can do now. There's different things you can focus on that you didn't necessarily have the opportunity to do when you were consulting. Now you can do. Now you've got some time to get into the nitty gritty and get into the weeds and really make an impact to work with physicians, technologists that you didn't have the time to do before. So,
yeah. And like, what does your daily interactions with techs, with radiologists, like what are your interactions with those folks looking like day to day? Are they constantly like hassling you for your input? Are you like rotating check-ins? How do you go about like allocating your time among the human side of things?
Everyone does it a little differently. Some people round in the morning. I don't really do that.
No.
Everyone knows where I'm at. We still cover the entire state of Indiana for Ascension. So we've got to be moving around all over the place, right? I may not be in my office, but everyone's got my cell phone. Technologists all have my cell phones. Department managers, department, obviously directors do. Radiologists have my cell phone. I work with radiologists a lot on CT protocols, MRI protocols, protocol optimization. We also work with the IR physicians. We're working with them just for more radiation protection. Provided we got the cardiologist wanted a new radiation protection device installed, and the state wouldn't allow it because of state regulations. It basically requires them. They can eliminate the use of wearing lead aprons, right, by using this device. And so we worked with the cardiologist. We worked with the State Department of Health to basically get an exemption so that they can use this device legally in the state and not have to wear lead, which is a great, stress reliever on the cardiologist that has to sit in, heavy lead for 8 hours a day, So
yeah,
technologists contact us if they have issues with fetal dose estimates, if they exposed a pregnant patient either knowingly or unknowingly. A lot of times we may need to perform calculations. A lot of times patients, specifically pediatric patients, parents have questions about their child's radiation exposure, and the technologists usually defer them to us to have those radiation risk conversations, in which we're happy to do because we spend a lot of time doing that too. So.
Yeah. So, I mean, like, we've talked a lot about the chaotic, the moving around, the busy schedule, but, we maybe touched on this a bit, but like, what's the best part of your day?
Yeah. I think the best part of my day is just we're support, right? We support everybody. I want to be supportive. If I'm not being supportive to the radiologists or the nuclear medicine physicians, or the technologist, or my hospital administration, or the cardiologist, or orthopedic surgeons who are using fluoroscopy, then we want to be a resource. We want people to know they can come to us with whatever question they have or whatever concern they have, and we want to help them. We also want to keep them safe. Sometimes we have to, explain why we're making policy decisions the way we are. So I feel like being that resource and being helpful is kind of I get a lot of gratitude. I'm grateful for being able to help people. And ultimately, if I'm helping them, then we're helping the patient in the long term, which is the whole goal, right?
Yeah, absolutely.
Healthcare has many cogs, right? And everybody has an important role. I don't think, from everyone, from housekeeping to security, to nursing, to physicians, to support staff, it takes a village to really make this thing work. And you can see the places where it's working right, and you can see the places where it's dysfunctional. And it's pretty obvious.
Yeah, I was talking to someone the other day who's also going to be coming on and doing this. He's seeing like this slow transition of physicists into like a glorified box checker. And it's so nice and refreshing and comforting to hear you still talking about the essence of what this job is, right? Which is patient care and support within these internal systems. Yeah, I don't know. It's really nice to hear.
Right. I see where he's coming from, because there are some things that I would say over the last 20 years, I've seen kind of drift away from medical physics involvement, at least not in teaching institutions or academic research, healthcare institutions, but in your clinical place, you're more, smaller hospital, community hospitals. Physicists used to have a lot of involvement in equipment bid specification and being able to get their hands involved on what hospitals purchased and help steer them in that direction. And now larger healthcare entities, conglomerates, they control all that through supply chain, and contracts are done and deals are done. And it's like, oh, you want a new scanner? This is the one you're getting. And we're like, well, wait, what if we want to get this option or that option? Well, we've done this analysis and we've determined that this is the type of scanner that you need. And so, that happens. I get it. There's power in, large national contracts, but that's kind of been lost. That art of being able to be part of that's kind of been lost.
Yeah, for sure. Okay, so before we start to wrap up, I am trying a bit of an experiment, and I guess you're effectively the guinea pig right now.
All right.
Which is, I have these 3 questions. I'm talking to all these different people in all of these different roles with different experiences, rural, urban, big, large health systems, small, independent places. I want to hear what different people have to say. So these can be long and expansive answers. These can be short, concise little sound bites and snippets. Truly, whatever feels like most natural to you. But I'm going to ask you 3 questions. Number 1, what is one truth in imaging that people just don't want to admit?
Burnout is real.
Hell yeah.
Burnout is real. I see it happening with everybody, physicians, technologists, physicists. Healthcare's not for the faint of heart. Nurses.
Yeah.
Everybody,
Yeah. Okay, number 2. What is one idea in radiology that you think we're wrong about?
May not be that we're wrong about it, but I think we're significantly underestimating what AI is going to look like in medical imaging. I know where it's the buzz. I know it's thing, but I think it's going to be on a whole nother level, to the point where I think there's going to be a lot more automation in 20 years, 10 years, a lot more than now. A lot more. Yeah.
And if you could change something or fix something instantly in this imaging sphere, what would you change right now?
I'll speak from a medical physics standpoint. I would make every hospital administrator take a course in medical physics. When I say a course, I mean, hi, I'm a medical physicist. This is what I do for you. This is why I'm important for your hospital. I keep you out of the newspaper. Those types of things. I think I would give because they don't learn that until the, quote unquote shit hits the fan, and we've either done our job or we haven't.
Right.
So either way, I think a lot of the hospital, and I'm not saying all hospital administrators. So my hospital administrator knows me by name, sees me in the hall, talks to me whenever he sees me. But I think there are other places, especially where there's consulting medical physicists in, they think they come in, put a sticker on the x-ray machine and walk out. And there's a lot more going on than just that,
Oh, yeah. Oh, cool. Will, that brings us to the end of our recording today. Thank you so much for talking to me. I really appreciate you.
Yeah, no, it's always fun. I appreciate the opportunity. I've been watching your podcast since it started.
Oh, thank you.
And you're doing a great job, and I enjoy it all. So thanks, Chris. Appreciate it.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.